Welcome to the deep dive. Today, we're getting into something really important and honestly often misunderstood: testosterone in women.
Yeah, it's definitely got that reputation, hasn't it? The male hormone. But its role in female health is, well, profound.
Exactly. And that's our mission today. We want to cut through some of that confusion, bust a few myths, and, shed light on the surprising truth about testosterone in female bodies.
And we've got some great sources to help us do that. We're leaning heavily on insights from Dr. Kelly Casperson's fantastic YouTube work, stuff like her 5 testosterone myths busted video and her chat with Caroline Labouchere, The Truth About Testosterone in Women. Really good stuff there.
Oh, yeah, very insightful.
Plus, we're digging into discussions and articles from ExcelMale.com. There's a lot of expertise there, contributions from people like Nelson Virgil, forum discussions involving Bobble Lee, Terload, Cretaceous. It's a real mix of clinical insights and lived experience.
So get ready. You might hear some things today that really challenge what you thought you knew about hormones. This isn't just about one little thing. It's fundamental. Okay, let's just jump right in then. Myth number 1. Testosterone is only for male bodies. I mean, that's the big one, right?
It really is. And, it's mostly historical baggage. Hormones kind of got gendered based on where scientists first stumbled upon them. Testosterone, rooster testicles, estrogen, cow ovaries. Simple as that initially.
Huh. Didn't know the specifics.
Yeah, but biologically, it's just not that simple. All our bodies, male, female, they make and absolutely need both testosterone and estrogen. And here's a kicker, something Dr. Casperson really emphasizes. Premenopausal women, the ones still cycling, they actually have about 4 to 5 times more testosterone than estrogen floating around.
4 to 5 times more. Wow. Okay, that turns things upside down. So does testosterone then, directly lead to estrogen in women?
It absolutely does. It's crucial. Estrogen is literally made from testosterone. It's part of this whole cholesterol pathway. About half of that conversion happens in the adrenal glands and the ovaries, and the other half that happens peripherally out in different body tissues.
So it's not just hanging around, it's actively being used to make estrogen.
Precisely. It's fundamental.
That makes so much sense why it's vital then.
Oh,
Okay, let's pivot slightly. Myth number 2. Giving testosterone to women in America is illegal. You hear this concern a lot.
yeah, and it's just plain wrong. Look, it's true, there aren't any FDA-approved testosterone products specifically dosed for women in the U.S. That's a fact. But prescribing it off-label, totally legal, and doctors have been doing it for, well, over 50 years.
50 years, so it's not some new, untested idea.
Not at all. But that lack of an FDA-approved female dose, it creates problems. Doctors often have to get creative, maybe microdosing products designed for men or relying on compounding pharmacies to make specific doses.
And insurance probably doesn't like that off-label part.
Exactly. Insurance often won't cover it because there's no official female product. So it becomes an out-of-pocket expense for many women, which is a real barrier. But despite all that, and some experts, you see this discussed on ExcelMale.com, they reckon maybe just as many women as men in the U.S. are actually using testosterone therapy now.
That's staggering, considering the hurdles. And ExcelMale really backs up its importance, right?
Hey.
Saying it's essential for women, affecting sex drive, mood, muscle, memory, cognition, too.
Yeah, all of the above. It's clearly not some niche thing, even if the system makes it seem that way sometimes.
Okay, so it's essential, it's legal, but what does it do?
Which brings us nicely to myth number 4. Testosterone is only for libido. That's the headline people grab onto.
Right, and look, the data is strongest for libido. A lot of studies, like those mentioned on ExcelMale, show clear benefits there, but that's just, scratching the surface.
There's more to it. Oh, way more. Dr. Kelly Casperson puts it really well. Libido is basically a mood, right? It starts in the brain. Testosterone helps with moods generally, so yeah, it helps libido, but its reach is much, much wider.
So what kind of other benefits are women reporting? Dr. Casperson and Caroline Labouchere talked about some, didn't they?
They did. Women talk about just feeling better, improved mood overall, thinking clearer. Dr. Casperson mentioned one woman recalling German she hadn't used in years, more energy, getting better results at the gym.
And that feeling of just being yourself again.
Yes, that comes up so often, that sense of feeling more like myself. And ExcelMale lists similar things. More energy, building lean muscle easier, feeling more motivated, that overall sense of well-being, more confidence, better memory. It really sounds like it touches everything.
It sounds like a fundamental shift for some. And thinking about the scale of the issue, ExcelMale brings up that 1999 JAMA study. Something like 43% of postmenopausal women experiencing sexual dysfunction.
Yeah, nearly half. And yet it's often swept under the rug, isn't it, compared to, say, male erectile dysfunction, which gets a lot more attention and has more readily available treatments.
Definitely a disparity there.
And it's worth noting, just quickly, there are other things out there now, too, like flibanserin, that's FDA approved for low desire in the US, works differently on dopamine in the brain, shows there are multiple angles being explored. Side effects are often even seen as perks, like better sleep or a bit of weight loss.
Interesting. Okay, so lots of benefits, but let's face that other big fear. Myth number 3, taking testosterone will turn you into a man. That must stop a lot of women in their tracks.
It's a huge fear, totally understandable, but fundamentally incorrect when we're talking about female hormone therapy. The absolute key is the dose.
Right.
Women are given what we call female physiologic doses, tiny amounts designed to mimic what a woman's body naturally has. We're talking 10 to 20 times less than a male dose. Masculinization. That only happens if you take male-level doses, which just isn't done for this kind of therapy.
And there's actual safety data to back that up.
Oh, yeah. Dr. Casperson makes a really powerful point using data from trans men. They take doses maybe 10 times higher than these female physiologic doses for their transition, and studies show they don't have an increased risk of cancer, death, or a lot of other major health issues.
Wow. This is very compelling evidence for the safety of the much lower female doses then.
It's extremely compelling. It really puts the risk into perspective.
Okay, but even at those lower appropriate doses, are there any side effects people should be aware of? ExcelMale mentions a couple.
Sure, like any treatment, there can be side effects, and they're usually dose dependent. The most common things women might notice at physiologic doses are maybe some mild acne or a bit more hair growth, what's called hirsutism, maybe some extra fuzz on the face or arms.
Right.
Now, if the dose was way too high, and again, this shouldn't happen with proper prescribing, you could potentially see voice deepening or clitoral enlargement, but that's rare, and it usually reverses if you just back off the dose.
Caroline Labouchere actually talked about getting whiskers, which understandably kind of freaked her out initially.
Yeah, exactly. And Dr. Casperson's advice is very practical. Look, if you get some extra hair, you can pluck it, shave it, use laser, whatever works for you. It's manageable.
And she had a tip about where you apply creams, too.
Right. Because if you apply creams or gels, say, on your inner arm or thigh, you might get a bit more hair growth right there. So she suggested, hey, why not put it on your legs? Most women shave their legs regularly anyway, so you might not even notice it.
Huh. That's pretty clever.
Hmm.
Okay, so creams and gels are common. What are the other ways women can take testosterone?
Well, there are low-dose injections, sublingual troches, those little lozenges that dissolve under your tongue, and subcutaneous pellets, which get inserted under the skin and release the hormones slowly. But yeah, the topical creams and gels are probably the most common, often from compounding pharmacies.
What compounding pharmacies specifically?
Because they can make custom doses. Since there's no standard FDA-approved female dose product, compounding allows the doctor to prescribe the exact strength needed for that individual woman. It allows for that fine-tuning.
Gotcha. Now, on ExcelMale, there was this really interesting forum thread. Bob Lee was talking about his wife. She was on a 10 milligram a day cream applied to her hip, but her free T levels were still super low, like 0.6 pgMLO. And there seemed to be a lot of confusion about the type of test used.
Yes, that thread highlights a critical point. Getting accurate measurements in women is tricky because the levels are naturally much lower than in men. Nelson Virgil, Terlode, Cretaceous, they all weighed in on the importance of the right test.
What's the right test then?
Often, what's recommended is a method called equilibrium dialysis for measuring free testosterone, free T. It's generally considered more accurate at these lower levels compared to some of the more common, cheaper direct assays, which can sometimes give misleading results in women. The timing of the test after application matters, too.
Okay, so the testing method itself is important. And you mentioned creams. Dr. Casperson warned about transfer risk, right?
She did. If you're using a topical cream or gel, there's a potential risk of transferring some of that hormone to, say, a child or a partner through skin contact.
So what's the advice there?
Her recommendation is pretty simple. Apply it somewhere like the inner thighs, let it absorb for a bit, and then put pants on. Create a physical barrier to minimize that transfer risk.
Makes sense. So if the blood levels can be tricky to measure accurately, and they fluctuate, should women and their doctors be chasing a specific number?
Dr. Casperson is really adamant about not obsessing over the numbers. Levels change throughout the day. Labs use different units, especially comparing US to Europe or Australia can drive you crazy.
So what should the focus be?
How you feel. Are your symptoms improving? Energy better? Mood lifted? The labs are a tool, a background guide to help adjust the dose if needed, but they shouldn't be the absolute target. Improving quality of life is the goal, not hitting some perfect number on a lab report.
Focus on the patient, not just the paper. I like that. Okay, let's tackle myth number 5. Testosterone therapy can't be used in premenopausal women, or it messes with fertility.
Yeah, another common one. And actually, it's quite the opposite in some cases. Some fertility clinics actually use testosterone protocols to try and improve egg quality and fertility outcomes.
Really? To improve it?
Yeah. Now, most of the big studies have been on postmenopausal women, but it's generally considered quite safe for premenopausal women too. There's good data showing it helps with libido in that group as well. But, and this is crucial, if a woman is premenopausal and still having periods, she absolutely must be on reliable birth control.
Why is that?
Because testosterone is category X in pregnancy. That means it's known to cause fetal harm. So preventing pregnancy while on testosterone therapy is non-negotiable for women who could conceive.
Got it. Very important point. Now, Dr. Casperson also pushed back against the idea that menopause is this sudden cliff where testosterone just disappears.
Right. She explained it's actually a much more gradual decline. It starts, believe it or not, in your 20s. Your levels begin to decrease linearly. By the time you hit your 40s, you often have about half the testosterone you had in your 20s.
Half. By your 40s.
Yep. And that decline continues into your 60s. So it's not like you're fine, then bam, menopause hits and it's gone. It's been declining for decades. Which also means women can have low T symptoms even while they're still getting regular periods.
So it's not tied just to period stopping. What about surgical menopause? Is that different?
Yes, that can be more dramatic. If the ovaries, the main testosterone factory for women, are removed surgically, then yeah, you can see a much more sudden and significant drop in levels.
Okay. So if it's declining from your 20s, it sounds like there isn't really a too late to start thinking about this.
Right.
People sometimes think you can't start after 60 or once you're well past menopause.
Exactly. That's another myth, often fueled by misinterpretations of the Old Women's Health Initiative study, the WHI. But remember, WHI looked at oral estrogen and progestin, not testosterone, and the findings were kind of overgeneralized.
So what's the current thinking on starting later?
The general guideline that came out of WHI was that it's safest to start hormone therapy within 10 years of menopause or around age 60. The idea is the body hasn't been without hormones for too long. But, as Dr. Casperson points out from her own practice, if a woman is healthy, active, maybe using transdermal estrogen, starting later, even in her 70s, can be quite safe and incredibly beneficial. The WHI fallout unfortunately scared a lot of doctors off prescribing hormones altogether for a while.
Right. Okay, now here's where I think it gets really interesting. Beyond mood, energy, libido, what other big health implications does testosterone have for women? Things that might really surprise people.
This is where some of the emerging data is just wow. Dr. Kelly Casperson mentioned 2 papers now. It's still early days, needs more research, but they suggested women on testosterone might have up to a 50% lower risk of breast cancer.
Lower, not higher.
Lower, yeah. I mean, that completely flips the old narrative, doesn't it?
Yeah.
ExcelMale's articles also touch on this, referencing one observational study finding that women on T plus other hormone therapy had breast cancer rates way lower than women on just hormone therapy alone in other studies, bringing it back closer to the rate in the general population. It's potentially huge.
That is huge. What else?
Well, both sources point to other key benefits. Bone health, really important for preventing osteoporosis. Muscle mass maintenance, which helps with metabolism and strength as we age. And cognitive benefits. There's some dementia data in men suggesting a protective effect, and the hope is it might apply to women too.
And heart health.
Also suggestive data there, yeah, that it might be heart protective. And interestingly, for postmenopausal women, because some testosterone converts to estrogen, it can actually help relieve those classic low estrogen symptoms too, the hot flashes, night sweats, mood swings, vaginal dryness.
So it's doing double duty in a way for postmenopausal women.
Exactly. It's quite remarkable, really.
It is. But it's hard not to think about the cloud that's hung over hormone therapy because of the WHI study, even though, as you said, it wasn't about testosterone.
Absolutely. It casts a long shadow. But more recent, specific data is helping to clear the air. ExcelMale highlights that 2019 Lancet meta-analysis, for instance. Huge study, 40 subs reports, over 8,000 women.
What did that find?
It confirmed testosterone significantly boosted sexual function, desire, arousal, orgasm, the whole lot. It did note some potential downsides with oral testosterone, like changes in cholesterol levels and the common side effects like acne and hair growth, but crucially, no signal of serious adverse events.
That's reassuring. Now, what about DHEA? Dr. Casperson mentions that sometimes. It's over the counter, isn't it? Is that like a shortcut?
Well, DHEA is a precursor hormone. Your body can convert it into both estrogen and testosterone, but it's an unregulated supplement in the US.
Meaning?
Meaning quality and dosage can vary wildly. You don't always know what you're getting. Some women might benefit, maybe premenopausal women whose bodies are better at doing that conversion. But Dr. Casperson shared she's seen side effects like oily skin, even crazy sex dreams. So it's not a magic bullet, and the lack of regulation is a concern. It's definitely not a direct replacement for prescribed testosterone.
Okay, good to know. So let's bring this back to the listener. With all this information, how can women feel empowered? What are some practical steps? Maybe starting with natural ways to support testosterone.
Dr. Casperson has some great, straightforward advice here. Number one, sleep. Regular, consistent sleep is huge for hormone balance. Then a clean diet, minimizing processed foods, avoiding things that disrupt hormones like excessive alcohol, marijuana, and definitely smoking. She points out smoking can actually bring on menopause up to 10 years earlier.
No, 10 years.
Yeah. And then exercise. Specifically weightlifting. Building and maintaining lean body mass is beneficial because fat tissue actually converts testosterone into estrogen. So more muscle, less fat generally helps keep testosterone levels healthier.
Makes sense. But even if you're doing all that, finding a doctor who's knowledgeable about this can be tough, right?
Yeah.
Dr. Casperson said many just weren't taught about testosterone in women in med school.
It's a massive gap in medical education, unfortunately, and that's where women really need to become their own advocates. Our medical system is often geared towards treating sickness, not necessarily optimizing wellness or preventing future problems.
So you have to speak up.
You really do. You have to bring up the conversation about hormones, about your sex life, about how you're feeling. Dr. Casperson shared this amazing stat. Estrogen therapy can cut the risk of diabetes by 30% in 1 year. If that was a pill, it'd be everywhere. But because it's a hormone, it somehow gets less priority. Women need to push for these discussions.
And there are access issues, too, beyond just finding a knowledgeable doctor. Like the example in Canada, free birth control, but not hormone therapy. That forces difficult choices.
It absolutely does. It creates inequalities in healthcare access based on cost. This all ties into Dr. Casperson's whole philosophy, the core message of her book, I Am Not Broken. It's about giving women the education to understand their bodies, to make informed choices, and to realize they aren't broken just because they're experiencing these symptoms.
And her point about living longer being unnatural.
Yeah, I love that framing. Historically, humans didn't live much past 45 or 50. Living to 80, 90, that's relatively new territory. So optimizing our health to live well during those extra decades, maybe that involves things our ancestors didn't need. Taking hormones, she argues, can be part of that modern toolkit for a long, healthy life, just like wearing glasses or brushing your teeth. It's not about being unnatural, it's about quality of life.
So if we had to boil it down, the biggest takeaway here seems crystal clear. Testosterone is absolutely vital for women. It affects so much more than just libido, and using it safely and appropriately can make a huge difference in quality of life, really, at any age.
Absolutely. And maybe that leaves us and you with a thought to chew on. If testosterone is this fundamental to female well-being, impacting everything from brain function to maybe even cancer risk, what are the wider ripples of it being overlooked for so long? How have the access issues shaped women's health? And looking forward, how could truly understanding its role reshape not just how we treat individuals, but maybe public health priorities and definitely how we train doctors?
Really powerful questions to end on. Thank you so much for joining us for this deep dive. We hope this has been enlightening, and we really encourage you to keep learning and advocating for your own health. Until next time.